Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.
Welcome to Always On EM. My name is Venk Bellamkonda. We're really excited to be your host for the show today.
Today, we're doing a deep dive into one of the hottest topics in alcohol withdrawal management, phenobarbital. That's right, we're talking about shifting paradigms, challenging the benzo orthodoxy, and getting our patients through withdrawal safely and effectively. Leading us on this deep dive is an absolute force in EM pharmacy. She completed her PharmD at the University of New Mexico and is now a PGY2 EM pharmacy resident with us here at Mayo. This is Dr. Brandy Hernandez. She's not just crushing it clinically. She has a number of peer-reviewed publications on nephrotoxic medications and the complexities of renally eliminated drugs. She's also the mind behind the electrifying Grand Rounds talk, Phenobarbi in a Benzo World, and she's here to break down the role of phenobarbital in alcohol withdrawal, what the evidence says, and how we can rethink our approach to this complicated topic. Folks, grab your coffee, silence those overhead pages, and get ready to learn. Please welcome to the show the brilliant Dr. Brandy Hernandez.
I'm excited to be here.
So Brandy, currently you're in pharmacy residency, and some people may not be familiar with what that is. Can you describe that?
Yes, pharmacy residency. So after pharmacy school for your doctoral degree, you're allowed the opportunity to go ahead and go to residency. So how pharmacy residency works more specifically is going to be a general PGY 1-year training, again, in more so commonly the hospital arena, but there is availability to do a postgraduate year 1 in things such as like AIM care or pediatrics right away. But where more so of our specialization leans towards is in a second year postgraduate residency, in which there's like so many different types. And I think I'm biased, but may have chosen the best as far as emergency medicine. But as far as what that entails is we're allowed this extra year of opportunity to learn more and be more involved, really take the time to be involved in projects, get into the nitty gritty with mentors and preceptors, and really take the chance to learn more on them before going on our own.
And this is voluntary, right?
Yes.
Very
yes.
cool. That I think it's amazing when people choose to take extra training, giving up their time and potentially leaving family and other things and putting their life goals on hold for just a moment to get extra training. It shows incredible character.
Thank you. It's definitely worth it.
That's so awesome. And do you have ideas on what you're going to do afterwards?
Yeah, so I'm very lucky to be staying on here as an emergency medicine pharmacist here in Rochester.
Awesome.
I think we're the lucky ones on that one. Definitely.
I'm lucky to be here and work with you all.
That is amazing. Well, congratulations to you and to us on that one.
Brandy regularly gets us out of big problems in the emergency department, always calling with an emergent question. So thank you for bailing us out all the time.
Anytime. That's what we're here for.
And on top of that, you taught us so much recently at a wonderful presentation, and that sparked this conversation. I don't want to give away too much, but maybe you can tell us a little bit, summarize what you talked to us about.
Yes, so I had the opportunity to give a Grand Rounds presentation on phenobarbital and alcohol withdrawal, really focusing on the literature behind its use and what we know so far. So really wanting to go into the pathophysiology and why phenobarbital might be more so attractive and compare it to benzodiazepines, which is more of the mainstay that we see more common in practice. Talk about its pharmacokinetics and the literature behind it, and then what we use here as our alcohol withdrawal management protocol, and when more so to lean on phenobarbital and when to not as well.
Is there something that sparked your interest in phenobarbital for this use?
I think being a new practitioner relatively soon and a resident now, I just wanted to personally be more comfortable with phenobarbital use in alcohol withdrawal. So I think looking into the literature, refreshing as far as like mechanism and pharmacokinetics was going to be really foundational to how I practice going forward. And I just wanted to overall be more comfortable with its use.
I think this is great because alcohol withdrawal syndromes and intoxication is something we deal with just so commonly. And I talk with Venk a lot about residue after a shift, and I'm far more likely to be thinking about these types of cases and the interactions that I had and how I could have done better than a case that just goes to the OR. And so I feel like this is a great opportunity for my improvement to help me take better care of my patients and to feel better after a shift. And so your talk was so inspiring, which is why we wanted to have you on to learn more as a group.
Phenobarbital was something that was commonly talked about when I was a student, but I really haven't revisited it in a long time. Can you get me caught up on how it works and where it might be used in medicine right now?
Yes, so phenobarbital is going to be more so of a common mainstay in seizure management, epilepsy management. But as far as specific to its use in alcohol withdrawal syndrome, I think about its mechanism as being two-part. So we still get that GABA integration with phenobarbital, and through acting on GABA, it results in an increase of calcium channel opening, and specifically it's proposed to work on more so the duration of the calcium channel opening as opposed to benzodiazepines really just increasing the frequency, which may be a proposed benefit. And then another proposed benefit as far as comparing it to benzodiazepines and its mechanism is also it has been hypothesized to work on the AMPA kinase receptor as well. So kind of like an analog to NMDA in which we get that neuronal excitability reduction, and is again an added benefit when you compare it to benzo. So that's it as far as like a mechanism background.
One thing I really appreciate is your expertise in the underlying pathophysiology of alcohol withdrawal. And I'd love to do a refresher in that because it's something that I look for all the time, but it's been years since I really paused to think about what's happening. What's going on when our patient shows up?
Is that because you're more focused on alcohol intoxication?
Yeah, you're right. You're exactly right.
Obviously, I'm just kidding. I don't think I've ever seen you intoxicated. But.
Yeah, so as far as the pathophysiology and summarizing that, we go back into understanding the mechanisms of what receptors we're specifically looking at, and which why makes benzodiazepines and phenobarbital make sense is going to be primarily through the GABA receptor. And alcohol works specifically on GABA to also cause the release of calcium, which then causes the CNS depression that we see in alcohol withdrawal. But then there's also an added mechanism as well, specifically focused on the NMDA receptor, which we're able to cause inhibition of that, which then also relates to the neuronal excitability reduction. And then I also like to categorize alcohol withdrawal as like a broad picture of what's going on. And we understand that there's a baseline homeostasis of our inhibitory or GABA and our excitatory or glutamate activity. And you, I, all of us in this room, the people listening, have a baseline of having those be equal. So with acute alcohol intoxication, the GABA activity is increased. And whenever you go into chronic alcohol withdrawal use, our body trying to maintain a new homeostasis will then increase our glutamate activity. So you can say whenever you go into alcohol withdrawal, you take away that excitatory, and then you have so much GABA that you essentially have to replace. So that's overall the major issue and why we lean on these agents to provide us more so exogenous GABA to combat those.
Thanks to some reading for the podcast, we found out that phenobarbital was discovered by two German chemists, Emil Fischer and Josef von Mering, in 1911. And as Brandy was mentioning, its use was primarily for seizures, but then broadened to anxiety, insomnia as well. And then, as she mentioned, benzodiazepines just basically kicked them out of the marketplace.
Exactly.
One thing that I appreciated so much about your presentation is it helped me think about a timeline. And you've just described so eloquently the mechanism and how we have a lot of abundant excitatory pathways, but we've kind of lost the inhibition that the patient's been adding for some time. Can you go through kind of a timeline of symptoms the patient might experience? Because sometimes a patient shows up and they have a little bit of alcohol in their syndrome. Can they start going into withdrawal? When do I start looking for these symptoms?
Yeah, those are very important questions and very foundational to alcohol withdrawal symptom presentation. And I think that's such a big reasoning why we asked when their last drink was to more so understand it. But things that you can look for primarily are going to be, day zero from last drink. You can really get those hallucinations that last around up to 6 days. And then our more common things that we always look for are going to be the excitatory things such as like tachycardia, hypertension, tremors, and insomnia. Those can last even upwards to 14 days or 2 weeks.
Wow.
I think what gets really interesting and where we want to keep our patients most safe, of course, is going to be for the very worrisome seizures. That time frame is going to be typically within 0 to 3 days. And then most relatively important and serious is going to be delirium tremens, as we know that has an increase in morbidity and mortality as well. That time frame is going to be anywhere from 2 to 4 days in which we specifically look for it. But again, understanding that each patient is dynamic, it's very important to get a good history, look at their history of alcohol withdrawal as well.
I think part of what you reframed for me and helped me focus on was the fact that we have this group of patients who are at high risk for showing up with altered mental status. And I think about the anchors and the bias that I have. And I might say, oh, well, there's frequent intoxication, but these subtle presentations, hallucinations, and things like that are cluing me into another life-threatening diagnosis. And so that was inspiring to me to reconsider things. When you're talking about seizures and delirium tremens, what are those? What's going on with that?
So the mechanism behind those specific items are going to be in knowing that then alcohol withdrawal, we also get an increase in dopamine, glutamate, and sodium. So seizures are going to be your typical seizures, but I think of delirium tremens being very much separated from that. So they're going to be having more so severe symptoms in which they can also have seizures combined, but this is wherever you're going to be more so worried for like severe hallucinations and other items like that.
I will say that as a creature of habit, I've had relatively good experiences with benzodiazepines, except then I kind of wander into oversedation. But I would love to hear your perspective. Like, what are the pros and cons of benzos? They're the workhorse, so to speak, of alcohol withdrawal. What do you see as the pros and cons?
Yeah, so I think you alluded to it well. We are in a benzo world, so to say. So we also have to understand that benzodiazepines as a whole have their limitations as well. But to touch on their benefits briefly, and something that we all know as why their mainstay now is that we know they're efficacious. We know they have a rapid onset of action. And then they also allow us to have various routes of administration, which is very, very important to us in the emergency department. But like you had mentioned, some concerns then would be respiratory depression as well as oversedation. There's also actually low literature in benzodiazepines use in refractory alcohol withdrawal where it may not prove as beneficial. But then from a pharmacist's perspective, it's also important to know, is there anything I can do to combat this risk of respiratory depression and oversedation? And overall, I would say that would be quite challenging. I think that if you were to go ahead and put benzodiazepines on a graph and you have, your increasing dose as your x-axis and your y-axis being your central nervous system effects that you are quite worried about, or when you want to know what dose equates to what exactly is to be expected from benzodiazepines, is that there is enough data to suggest, or we understand that benzodiazepines at lower doses can result in sedation or anxiolysis. However, we don't know exactly what dose can cause respiratory depression. And I think that's what is very worrisome when we use benzodiazepines, just because there is a high interpatient variability whenever we are to use them at the varying doses. And another reason why I think phenobarbital may be more so attractive based on pharmacokinetics is that we actually do have a lot of information to tell us what we can expect based on the doses we use. And this has all been done through studies that look at specific therapeutic levels, again, primarily in the use of seizures or epilepsy. But we can understand that whenever we use doses of phenobarbital, the same that are more likely utilized in alcohol withdrawal management, is that we're really in that therapeutic range and we're really not getting up to higher doses where we'd be worried about those adverse effects such as like toxicity or stupor or coma. So I think it's pharmacokinetics and being very linear as opposed to benzodiazepines really lends to its attractiveness in alcohol withdrawal.
So basically, you're throwing some shade on my benzos, and in the words of one of my favorite songs, they're predictably unpredictable.
Yes.
Okay, I like that.
No shade. They're lovely as well. They're lovely as well.
On an ICU rotation, one time I expressed that I think I could do most of my job if you give me midazolam or lorazepam and epi and azole. I think I could do like the majority of what I need to do. Just changing the doses around.
The acute things.
I could get through a lot of my shift, and so I like this. Okay, so
I'm surprised you didn't say ketamine.
well, so if you give me something to achieve some sedation, but now I'm going to have something to add to my armamentarium. So a key issue with benzos is sedation, and particularly we can't really predict when the sedation will occur. And this occurs, I think, in a lot of aspects of benzos. When we think about previously doing sedations with a little, fentanyl, a little Versed, you never really knew when you were going to trip and fall into needing to bag the patient, which is different than other meds. And so what we're saying is phenobarb is much more predictable.
Yes.
Okay.
In one other area I'm curious, are there a lot of drug interactions with phenobarbital? I know with benzodiazepines, you can get stacked respiratory depression with other medications.
Yes, I think of more so phenobarbital's use in the long term being very concerning for drug-to-drug interactions, in which, if you think about this patient being transferred to the ICU or floor, whatever your internal protocol is you really have to think about the efficacy of the other agents that this drug-to-drug interaction may occur. And unfortunately, it is going to be more so with anti-epileptics like valproic acid, phenytoin, lamotrigine. So it's just very important to be cognizant of those, and it is one consideration that I would recommend for all providers. I'm just thinking more so in the long term, and that the medications that does have drug-to-drug interactions and are important and should be considered.
Brandy, during your talk, I was struck by your use of evidence. It was an amazing display of providing great synopsis as well as supported by wonderful evidence. And as you think about a number of the studies, especially when we're comparing the benzodiazepines against phenobarbital, are there any that you want to highlight for the literature, for the listeners?
I think some to go ahead and highlight are going to be those that I categorize in my presentation as more so looking at efficacy. And I denoted that by having these studies look at the outcomes of change in CWAS scores or symptom management. And I think the one that I want to more so draw out is the study in 2019 by Nicevic et al., really looking at phenobarbital viability. I would say if I were to categorize exactly what patient population that the study looked at, it was going to be more so in our severe alcohol withdrawal patients. It was a retrospective chart review in which they looked at fixed dose diazepam or lorazepam versus phenobarbital. Their dosing strategy was interesting to me in that it was intramuscular, given 3 doses, 3 hours apart. And based off of a weight-based dose, which they looked at from assessing whether or not their patient was low risk, moderate, or high risk, and then their concern for sedation, they would give that initial dose 40% as that first dose, then 30% of that total dose 3 hours apart, then 30% of the total dose 3 hours apart. So again, very unique. And then it was also followed by oral phenobarbital maintenance. And I think that this one was specifically important because it's actually one of the only ones that looks at, again, from an efficacy standpoint. So they really wanted to understand if these patients were to develop complications such as seizures, hallucinations, or delirium, which I think are very patient-centered outcomes. They also looked at secondary outcomes such as hospital length of stay as well as ICU length of stay. But I think the one important thing, and if I were to summarize it in total, is that they really proved that phenobarbital was as efficacious as benzodiazepines with no significant outcome difference. But specific to the study, I find it very interesting that they looked at a benzodiazepine refractory population, and this is where we see that maybe added benefit as well in context of switching, and overall they saw that it was also a viable alternative in this specific scenario as well. So again, on its own, and then in your patients that are benzodiazepine refractory, in which they saw those decrease or similar outcomes as far as seizure, hallucination, and delirium.
And I think that one was a retrospective study and had all those great qualities, and then you followed it with a prospective randomized trial in case somebody was somewhat skeptical of the retrospective design. So you counterbalance to give a more validated research methodology. Can you talk about that one?
Yeah, it's a study by Rosenson et al. in 2013. And in my bucket in the landscape of describing alcohol withdrawal management, I more so look at this study as looking at associated outcomes of phenobarbital and alcohol withdrawal syndrome. And what I mean by this is their primary outcomes are more so going to be related to like the hospital length of stay, where the patient was admitted as far as like level of admission, hospital admission. But the study by Rosenthal was also great, in which it was, like you mentioned, prospective and randomized as well as double blind. Their intervention was going to be comparing phenobarbital. They used a 10 mg per kg bolus over 30 minutes, and then they actually used a placebo, which was 100 mils of normal saline over 30 minutes. Either group could have symptom-triggered lorazepam as well. Another thing that was interesting to this study, but again, similar as far as how we go ahead and categorize based off CWA or whatever scoring system you may use, but this one specifically had a scoring system known to their institution, which is called AWCA or ACA. I'm not going to give it a fancy name, but hopefully one of those is correct. And they again saw that more so, again, associated outcomes are going to be a decrease in ICU admission rate, phenobarbital 8 versus placebo 25, which is important. And then they also saw more so benefits such as like hospital length of stay, ICU length of stay as well. No significant adverse events.
And then when you gave your presentation, Drs. Carpenter and Belolio had some thoughts on the retrospective design studies and how we should potentially also qualify their results. Do you mind commenting on that?
Yeah, so I think knowing what type of study, of course, is important. And I agreed with them completely, in which a lot of the studies are going to be retrospective with respect to looking at phenobarbital and alcohol withdrawal. And I think this just has to open your mind and understanding that given to its retrospective nature, you have to be careful in how you go ahead and analyze the results, because these patients may have been more severe. They usually also have a concomitant use of benzodiazepines, which can also skew the results. So it's just important to look at it from that lens. And I think that's what they were trying to allude to as well.
Yeah, that's what I took away as well, that even though especially because it was retrospective, the patients in the phenobarbital group had some reason that they were put that way, most likely. And so that any differences in favor of phenobarbital, we should take and even highlight even more. Mm-hmm. And so more to your point.
With regards to thinking through other reasons where I might not reach for phenobarb, other than medications that the patient is on, anti-seizure meds, are there any physiologic issues that I would reach for something else?
Yes, I think there are some important considerations to go ahead and not use or stray away from phenobarbital that I think would be important to discuss. So like you had mentioned, we already talked about the drug-to-drug interactions. I think that based off of its pharmacokinetics as well, if you have more so any degree of hepatic impairment in your patients, which again isn't well defined by our prescribing criteria as far as giving us a Charles Pugh class A, B, C, whatever it may be. But from what we go ahead and practice, it's going to be really mitigating its use into compensated liver cirrhosis as a marker of hepatic impairment. We also want to then stray away from phenobarbital's use if you have any component of hepatic encephalopathy. Porphyria is also listed as one of the things you would want to stay away from, as well as concern for respiratory depression.
Okay. So if they're already so sedated that they have respiratory depression, it's a no-go. It sounds like cirrhosis by itself, some history of cirrhosis might be okay, but not decompensated cirrhosis. So if I'm tapping the belly and things like that, I might pick something else.
Exactly.
Okay. I think we're better understanding the mechanisms. We have an idea of who this might work in, but let's put it into practice. This is when I'm going to be calling you on my next shift and saying, would this be the right situation? So how are we risk stratifying patients and trying to find a right dose and medication?
Yeah, so I think risk stratification really leans on their symptom presentation and what symptoms they have at presentation. I think our specific protocol really guides it as like non-urgent symptom control, urgent symptom control, and then delirium tremens. I also like to think about it as like mild, moderate, severe. So for our more mild patients, these are patients where you can understand to be hours to days after their last drink. They have no altered mental status, and you're possibly anticipating discharge. Given the fact that, again, phenobarbital isn't well studied in this specific patient population, this is why it's not more so integrated into the lower risk of alcohol withdrawal algorithm. So here we really lean on our CWA-triggered oral benzodiazepines, such as lorazepam, diazepam, chlordiazepoxide, dependent on provider preference, and that more so guides the mild or non-urgent symptom control category.
And so for mild, we're really talking about patients who are pretty recently from their last drink. They're not altered and we think they're going to be discharged. Is there a specific CWA that corresponds to this?
I understand that our own protocol does allow for CWAs. Usually 10 is the minimum.
Okay.
To be considered to give a benzodiazepine.
Okay. So below that, we're kind of observing. At 10, we're saying we're going to do some symptomatic management. And looking through our protocols, it looks like somewhere between 10 and 18, kind of. And what types of meds are an option at our shop?
Yeah, the types of meds that we can use and lean towards, again, really choosing our oral options to necessitate the need of an IV, hopefully, and understanding, again, they're in that low-risk category. You'll more so lean towards lorazepam, diazepam, or chlordiazepoxide.
Among those, which one are you leaning to, Alex?
Lorazepam all day. I mean, I think the main thing is that's just kind of how I trained in general. There's a lot of opportunities. Brandy, when would you reach for diazepam here? When would you reach for something different if it's all about the same?
You know, honestly, I do see them as all about the same. So again, I'm not going to have any preference from a pharmacy's perspective and really lean on the physician's comfortability.
Cool.
Distantly, I remember being taught, I don't know how it stacks up in the evidence, but that Librium, I think that's chlordiazepoxide, has less euphoria and thus theoretically would help patients not potentiate their addiction, but that was a long time ago. So in these patients, if I want to send them home, especially with some in the right context, then I usually go to that. But because it takes time to get from pharmacy, it's not something I usually give in the ED. If I'm going to treat in the ED, I usually give them what we have in the Pyxis, which is lorazepam.
You brought up a great question for me, Venk, which is, which types of patients go home? So I think a challenging component of these patients are disposition. And I think for me, really, I'm seeing a group of patients who might be able to go home, and I'm trying to think of how I can manage their symptoms safely if they choose that they want those symptoms managed. Then I have inpatient admission, and I have also some supervised withdrawal centers. Venk, when you're working through that acutely, how do you navigate that? What type of patient, first of all, do you think needs admission versus could go to a detox facility if they don't, either they lack capacity to make a choice at that moment, or they want detox and don't need medical admission? What types of aspects of the history are you listening for?
That is a big question
and
a really good one. I'm going to assume that there might be some variability in the particular centers that our listeners are having in their communities. So to everyone listening, I'll just describe what we have. We have a county detox facility that does not manage anyone who has a history of withdrawal seizures. They do not provide much in the way of ongoing counseling services. They really provide first-line medication assistance for the first 72 hours of withdrawal, and it's not very personalized or tailored. They do their best. I don't mean this in any way. It's not intended to be disparaging, but just the realities of it in terms of staffing and funding. It's a somewhat challenging place for patients, and a lot of patients seem to tell me that their experience there is something they would rather not go through. And then inpatient, we don't have as many beds anymore, but previously, prior to the pandemic, we used to have more resources where we could bring patients into the hospital, and we had various protocols, whether it be gabapentin or phenobarbital or lorazepam, and we had inpatient addictions consult services and things like that. So this is the environment we used to live in that formed my practice. I have to recalibrate now that we have almost no inpatient beds every night. So even our patients with pneumonia and sepsis and whatnot, we're trying hard to find resources for them. So I'll answer in that context. For me, if a patient is intensely motivated to quit and become sober, then I used to bring them into the hospital, to hospital medicine. If they were not motivated to quit, but they needed a place to become sober so that we could evaluate something else like suicidality, then I used to send them to detox. And then if they did not want to quit and they were not needing to be sober for something else, I used to make sure they were safe enough to walk, or at least ambulate at their baseline. If they came in a wheelchair, they left in a wheelchair, that kind of thing. And then I would let them go when they were safe and their goals of that ED visit were met.
I trained under you, so I have a similar approach, but I think in our practice, really we're trying to use scoring systems, and if it's a very high-risk patient, they come in particular, seizures for us are often a differentiating factor on if some of these other facilities will accept a patient. But then there's this other group, a patient that wants to quit, does not want to go to detox. What types of factors, and Venk looking at it from a physician point of view and Brandy looking at it from a pharmacist point of view, what is the ideal patient who you might send home with medications to manage withdrawal?
I think that is such a tough question, just because of course you want to make sure that they're safe overall. And looking at the side effect profile of each phenobarbital and benzodiazepines, we won't necessarily, as a pharmacist, of course, negate who will go home. But I think based off of, and a common question that comes up is, which one would you rather them be on, phenobarbital or benzodiazepine at home? I will be in the camp in which phenobarbital, just based off of its pharmacokinetics, might be a more safer option. But again, we of course want to stay away from any drinking on either.
For me, I'm looking for ideally a person who has social support. So there's someone else or multiple other people. And there's someone else or multiple other people who are in their community or in their home life that can be there to support them in this short term while they're working through their withdrawal syndrome. This is a person who is willing to commit to going through some unpleasantness, but also understanding that this is a dangerous period. Ideally, someone that does not score high in terms of suicide risk, and then somebody who has a pretty decent medical literacy to understand these very complicated interactions between alcohol and the medications. Then I also need a lot of time to do counseling, and I usually write down and create some graphical figures of how they're going to taper down the medications over time, and I'm going to write it out explicitly, and ideally they have good follow-up. So it's a very rare thing I do anymore, but before, when I was more in the psychiatry role, I did it occasionally. I still do it, and I did it when I was at the VA in the emergency department there, because I could get more close follow-up and things like that. And I have done it at the county hospital once, I remember, where I had them come back to the ED every day and check in with me. I was working a series of shifts, and I let them go, and I had them come back in to check in with me every day. And for that short period, they were quite successful.
When I'm considering the pharmacology of Librium, lorazepam, diazepam, oxazepam, and then phenobarb, can you walk me through a little bit of what's going to act faster, what's going to act longer, as I'm trying to target my patients' therapies?
Yeah, so there is much variability just in benzodiazepines as a whole, so we can touch on those briefly at the beginning. But like you said, for the ones that more common, so mentioned chlordiazepoxide, onset of action is really depicted to be around 30 to 120 minutes. Lorazepam, it's really going to depend on what route you're using, but any words up to 15 minutes if you give them an IV dose. Here in the ED, oral is going to be about 20 minutes. And then diazepam, 0 to 1 IV oral, 15 to 30 minutes. Oxazepam, again, isn't most commonly used, but if you were curious about that one, the onset of action is going to be around 120 to 180 minutes. Benzodiazepines as a whole are more so categorized if they're long, intermediate, or short acting. Diazepoxide and diazepam would fall more so into the long category, with lorazepam being more so intermediate. And then for a phenobarbital standpoint, as far as its pharmacokinetics, these are going to be very distinct, in which the IV formulation, it's usually going to take much more longer than our benzodiazepines, typically around greater than 6 hours for a duration of action, and then oral for a duration of action around 10 to 12 hours. Now the onset is 5 to 15 minutes IV, oral typically greater than or equal to about an hour. I think the most important thing to touch on from a pharmacokinetic standpoint with phenobarbital is its half-life being so long. So it's about 53 to 118 hours. So if we understand that it takes about 5 half-lives for a drug to be out of the system, it's going to take quite some time. So again, as far as like more so onset, typically the same when you look at IV phenobarbital and benzodiazepines, but the half-life is really what's differ between the two, phenobarbital being much, much longer.
So for this mild group, we have a couple of benzo options. We have chlordiazepoxide as an option, and we're proposing a new homegoing option, which is considering phenobarb. If a reader wanted to learn more about a dosing strategy for someone to go home, is there a textbook that you would recommend? Is there something that a reader could look into for their institution for these mild patients who might go home?
Unfortunately, I do not, and I feel like it's very provider or institution specific, especially as it might not be so more mainstay for them to discharge on phenobarbital quite yet.
Alex, we've been talking a lot about the mild alcohol withdrawal patient, but it feels like to me overnight, I see a lot more of the patients who have diaphoresis, tachycardia, they're agitated. How would you categorize this patient, and how am I going to help them?
Yes, so for these patients, it's going to more so fall into the moderate category based off of what you are describing. So these are the patients where we really want to lean on more so urgent symptom control. They're going to be hours to days after their last week, have those hallucinations, agitation, hypertension, tachycardia, or more so activated symptoms. For agents that we use in the specific category, again, specific to our institution, is going to be either the use of phenobarbital or benzodiazepine, specifically in the IV formulation. And as we've already discussed, really deciding on the pros and cons, and if you believe phenobarbital safe, or it may be also a comfortability item to decide which pathway you choose. But we can understand that the IV benzodiazepines that we are going to really lean on are lorazepam or diazepam. Diazepam if you have lorazepam shorted, and then phenobarbital on its own. But more specifically, you're again looking at patients with at least a lowest CWAS score of around 10, and with the ability to go ahead and switch agents if they were to become more so like refractory or meet our criteria for max dosings to fall into the other category for agent.
I've personally never prescribed phenobarbital, and I'm trying to figure out how to incorporate it into my practice. Are we saying the goal of this medication in general is I have a patient who's kind of moderate and I'm going to treat them with an IV formulation or oral formulation, get them low risk, and then they have a disposition that could be home or to some place like our county referral center because now their symptoms are better managed and I'm going to send them out with some lorazepam or something like that? Or are we saying we're going to give them this medication and then they're going to go home with the medication as well?
I feel like that isn't something that's very much touched on within our specific protocol here.
Yeah.
So again, I hate to say this part again, but I feel like, again, very provider specific in which they choose whether or not to go ahead and allow these patients in the moderate category to go home. But it's just providing a resource in which we're able to fluctuate or flip-flop between using either agent.
Perfect. And so overall, you have a moderate risk patient, you're picking a pathway, and one thing that we're considering that's newer is phenobarb, and then they get admitted on a phenobarb protocol if that's appropriate. Or I was just thinking about the interesting endpoint you described where length of stay and disposition was in some of those other studies. And so what was interesting to me in those studies was it sounded like they were getting IM or something like that, and suddenly that was kind of the endpoint. And I was thinking, what would I do with that patient if they got a bunch of IM phenobarb? But it sounds like overall we are generally going to potentially start phenobarbital and admit the patient on phenobarbital, or they can change to something else inpatient, or we're reassessing them and their symptoms have greatly improved. In our kind of ED protocol, oftentimes we'll consider then, if they're going home, switching to a benzo or Librium for going home. Is that right? It's less common to discharge on phenobarb. Exactly. Perfect.
So we've talked about mild, talked about moderate. There's got to be a severe category. Take us through that one.
Yeah, the severe category. This one's going to really have to deal with whether or not you're worried about delirium tremens or...
Is ECMO on this?
No.
But it should be.
Really just focusing on, again, looking at them looking at the patient from a timeline perspective, understanding if they're around 2 to 4 days from their last drink to understand if they're in that window. But then they can also have an accumulation of those activated symptoms such as hallucinations, disorientation, tachycardia, hypertension, those things. The more so severe category, or what we more so define as active DT, we want to go ahead and use, or we have integrated into our protocol, phenobarbital as an IV. This is going to be specifically using it as a 10 mg per kg loading dose based off of ideal body weight specifically. And we max this dose at 1040 milligrams.
I'm struggling a little bit to think the being at risk for a DT versus the moderate group. How do I distinguish those two again?
So the moderate group, or to clarify, the severe group is active DT.
Oh, they have DT.
Mm-hmm. Yes.
Got it.
And then the moderate group is just going to be those urgent symptom control, more so activated. You're possibly not going to think of this patient as...
Okay. So as soon as you have DTs, you're into the severe group.
Yes.
Okay. Is there any other group that we should be aware of?
I don't think so.
Okay. So we've got mild, moderate, severe. Moderate is going to be, they have intense symptoms, they need immediate therapy, but they don't have DTs. Severe has DTs.
Mm-hmm.
Mild is something less than those intense symptoms, and they could likely go home. That's really helpful.
And we're defining DTs as the presence of hallucinations, disorientation, and then just this kind of sympathetic storm of tachycardia, hypertension, hyperthermia, agitated, and diaphoretic, different from the picture of seizures. Is that right?
DT is quite complex in that it's categorized as a severe or life-threatening condition that encompasses all the symptoms.
Okay.
But I think one thing to consider when you look at DT as a whole is understanding the severity. So these patients are going to have severe acute confusion. They're going to have hallucinations, and they're usually going to be very visual, auditory, tactile, whatever it may be, but to a severe degree. They're going to have tremors. They're going to have also a component of autonomic instability, and then the seizures as well can be a component as well. So I think grouping it together and understanding that these are the more severe patients is whenever DT should be on the forefront of your brain.
That's really helpful.
I was going to say that.
Absolutely.
I haven't seen it that often, so I think from my understanding, that's what it would be.
This is very helpful. Now, this protocol, how often are you seeing our teams deploying this in Rochester?
I will be honest in that I've never used phenobarbital for alcohol withdrawal here.
Okay. What are the barriers in our team deploying it?
I think some of the barriers are going to be, again, with what we touched on with a lot of this stuff, is going to be the provider comfortability in knowing what to expect from phenobarbital. I also think maybe that a component might be our specific alcohol use disorder population, that they might not necessarily always have the severe of alcohol withdrawal. And then thirdly, I think one of the biggest components is going to be our institutional protocols as far as whether or not phenobarbital can be used on the floor or general floor patients, which it can't. So I feel like that really mitigates its use, and something that's being in the works as far as to see if that's something that we can implement. And then I can maybe foresee us using it more, because we know that if we use it, it's kind of a guaranteed ICU stay.
Let's talk nationally. Where does the Society of Academic Emergency Medicine fall on phenobarbital?
Yeah, so SAAM GRACE 4 guidelines really touch on this, in which they go ahead and recommend the use of phenobarbital in conjunction to benzodiazepines rather than benzodiazepines on their own.
Do you happen to know any of the authors on that study?
I think, yes, there's 2 of them from here.
Yes.
I think there was a really review article or systematic review that they were a part of that went into this guideline. But again, really focusing on the fact that understanding alcohol withdrawal management literature is very hard, just because everyone uses so many different protocols, different doses, plus benzodiazepines. If you use fixed dose versus symptom triggered benzodiazepines, we also saw how variable the scoring systems are. A lot of institutions do use CWA, but some have their own. So it's very dynamic and very hard to conceptualize as a whole to understand where the literature lands as far as understanding which agents we should use or if there should be a preferred agent.
That makes sense. Okay, so if you're listening out there, this is something that the Academic Emergency Medicine Society is endorsing that we should use in conjunction with benzodiazepines for several good reasons. You can check out the paper. if you're looking at the literature, there's great studies. Many of them are retrospective and that inherently has some limitations, but since these retrospective studies are favoring phenobarbital and there's inherently a bias to use phenobarbital on more of the sickest or more refractory patients and to use benzodiazepines as kind of first-line therapy, there's a suggestion that that would mean that phenobarbital is even more effective, at least it's suggestion. There are prospective studies that Brandy's already brought up that show these secondary measures are improved with phenobarbital. And then we've talked through some proposed algorithms for mild, moderate, and severe alcohol withdrawal states, severe being with DTs, moderate being with acute symptoms, vital sign abnormalities, agitation, moderate hallucinations, etc., and then mild being the patient who's having some mild withdrawal symptoms that you could treat and maybe send home. And then we've covered some of the things that you need to be careful with phenobarbital if the patient has liver impairment, hepatic encephalopathy, porphyrias, if they have certain long-term drug interaction concerns, things like that you'd want to watch out for. But this is something that we need to be thinking about, it sounds like, and that in this next phase of our careers, we might be doing this more and more. That's what I'm taking away from this. Is that what I should be taking away, Brandy?
I believe that is what you should be taking away, yes. I feel like a lot of institutions may so already lean on it a lot more so, especially with benzodiazepine.
Yeah, actually that was something I was just seeing. So at our institution, we're running into some lorazepam issues. And so the only 2 medications I need, and lorazepam, you're taking one away. What, just a supply chain issue?
Yes, I believe a supply chain issue primarily. Wow. Yep. So
okay.
Hopefully we'll get back on board soon.
Well, no better way to embrace a change than being forced to make the change, right? So I love it.
Exactly. Alex, I feel like I know of CEWA, but I don't know it in great detail, or I don't really know any more detail than just clicking the orders on Epic. Do you know anything more about it that you could fill in?
Only what I've prepared. I definitely agree that I think our nursing staff are the experts in scoring, because that is kind of how in our practice it's set up. But overall, the CEWA is the Clinical Institute Withdrawal Assessment for Alcohol Revised. Now it's the CEWA-R. And essentially, it is for symptom-triggered therapy. And so you're continually reassessing these symptoms to identify a threshold for medication intervention and then to try and help guide your dosing. And so anyone, if you look on MD-Calc, other scoring tools, you can pull it up, but you're asking questions about nausea and vomiting and the severity of that. You're then looking for a degree of tremor, paroxysmal sweats, anxiety, agitation, tactile disturbances, auditory disturbances, visual disturbances, headache or a fullness in the head, orientation and clouding of sensorium, and asked by questions like what day is it, where are you, etc. So you generate a total point score based on that, and then we'll help risk stratify you into mild, moderate, or severe and help guide some dosing. Does that sound right to everyone? That's
really interesting, because that fits clinically with what I've seen, that I'll see with withdrawal vital signs, and they won't be getting any medicines for that, tachycardia and hypertension. And that makes sense because it's nowhere in the score.
Yeah. And that's what's popping up on my screen. That's what I'm looking at right away too. So
yeah, fascinating. And no wonder, like a lot of times I'll be trying to get the vital signs to be better, and I'll put the CEWA score on, and I can't admit the patient to the floor or anything because the vitals aren't better, and the patient looks uncomfortable, but I can see why they're not getting medicines based on this. It only took, almost 20 years for me to investigate further. Thank you, Alex, teaching me something here. Thank you so much, Brandy.
Thank you for your hard
Thank
work.
you.
This was
This
phenomenal.
The Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.